In this video, we will learn about the tribology of joint. Learning objectives: to know the basic physics behind wear, generation, distribution and effects of wear particles, and to know what the polyethylene and metal debris do to the body. Tribology deals with three factors: wear, friction, and lubrication. Wear is the main cause of deformation, and it happens due to removal of material from the surfaces due to mechanical interaction. Friction is the force that opposes the movement. Lubrication is the mechanism to reduce friction and wear at the joint surfaces. Now let's look at the first property, wear. Two surfaces, surface 1 and surface 2, are in sliding contact with one another. The unevenness on these contact surfaces are called asperities. When these surfaces are in relative motion, a shearing force is produced on these particles, and some of them, especially from the softer surface, do get detached and they get attached to the other surface. Such a process is called adhesive wear. Similarly, if two surfaces are in sliding contact with one another, one much harder than the other, the asperities or the protuberances of the hard surface flows into and displaces some material from the soft surface. However, these particles do not attach to the other hard surface. Such a wear is called abrasive wear. It is also called two-body wear. A three-body wear is a variant of abrasive wear. Here, the abrasive slurry, or some hard particles related or unrelated to either of the surfaces, are trapped between the moving surfaces. These particles are free to roll and slide, and they displace particles from the other surfaces. To summarize, wear can be adhesive wear, abrasive wear, which includes two-body wear or three-body wear, and fatigue wear, which begins as surface and subsurface cracks due to strain induced by cyclical loading. Before we proceed further to the specifics of wear particles, let's get a look at the stress-strain curve. Stress is the force applied per unit area of a material, and strain is the deformation of the material, or a ratio of change in length to the original length. If we subject a material to stress and plot its strain on a graph, we get the following curve. Initially, up to a point, the stress-strain curve is linear, that is, strain is proportional to the applied stress. This is called Hooke's law. The point at which this linear relationship ends is called proportional limit. Deformation during this stage is reversible. The slope of the line, which is stress divided by strain, is called Young's modulus, and it represents the material stiffness. Beyond the proportional limit, the stress-strain plot is nonlinear, but the deformation is still reversible up to a level called yield point. The curve till this level represents elastic zone. Beyond the yield point, the material can withstand further stress and reaches a peak which is termed ultimate tensile strength. Further application of stress causes the material to fail at the breaking point. The part of the curve beyond the elastic zone is the plastic zone, where the deformation is permanent. If we measure the modulus of elasticity of materials of interest in orthopedics, this is the result. The stiffest material is ceramic, followed by cobalt chromium molybdenum, followed by stainless steel, titanium, then cortical bone cement, polyethylene, and cancellous bone. Note that the polyethylene is softer than the bone cement, and it is important to remove any loose bone cement during joint replacement to avoid a three-body wear. Now let's come back to the polyethylene wear particles. In hip arthroplasty, the polyethylene particles generated are of submicron size, and they arise from head cup articulation or backside wear from cup acetabular junction. The generated wear particles are phagocytosized by the macrophages, and these macrophages release inflammatory cytokines that helps to recruit more macrophages in a positive feedback loop. The cytokines also stimulate osteoblasts to secrete rank ligand or receptor activator for nuclear factor kappa beta. These bind to rank receptors on the osteoclasts and activate them, and the activated osteoclasts release enzymes that cause osteolysis and aseptic loosening. The distribution of these wear particles is also interesting. The intra-articular inflammation elicited by the polyethylene causes increased intra-articular hydrostatic pressure. This pumps the polyethylene particles into what's called an effective joint space. Effective joint space is demarcated by contact of the implant or the cement with the bone. Predictably, the polyethylene particles follow the path of least resistance. They are seen early on around the screw holes and around the cement mantle defects. In an uncemented stem, it's important to note the distribution. An extensively porous coated stem is well fixed distally, allowing proximal stress shielding. This, along with proximal accumulation of polyethylene particles, lead to a more extensive proximal osteolysis. A proximal porous coated stem is well fixed proximally, and hence distal osteolysis is more common. It's important to note that the type of polyethylene wear is related to the femoral head size. The linear wear occurs when a small femoral head is used due to a low contact area and high stress. The hip failure is mostly due to polyethylene wear, and it would need revision of the cup as a treatment. The volumetric wear occurs when a large femoral head is used. Here, the contact area is much larger and the stress is low. As the head flows through it, it creates a cylindrical defect in the polyethylene. Hip failure here is mostly due to polyethylene debris-induced osteolysis, and a total joint revision is usually necessary. The volume of debris generated is much more than in the linear wear. If R is the radius of the head and H is the wear thickness, then the volume of debris is given by the volume of the cylinder, V equals pi R square H. The radiological effects of osteolysis usually takes many years to develop. The classical findings are endosteal scalloping of the femoral canal and round lytic areas around the acetabular cup and screws. It's important to remember that osteolysis, which are permeative and which appear during early years after arthroplasty, could be infective in nature. Another point to note here is the effect of host response to wear particles. Despite the same amount of polyethylene debris, some individuals have much less osteolysis than most others, and a probable cause is that they have less immunological responses to these wear particles. It is also thought that some people remove the debris more efficiently from the joint through an effective lymphatic drainage, reducing the local concentration of the wear particles. So, with this background, let's look at the ways to reduce the possibilities of polyethylene-induced osteolysis. A correct surgical procedure helps to restore the center of rotation of the hip. Hence, keep the joint reaction forces to the minimum and in turn reduce wear. Use of alternate bearings is another option which I will discuss in another video. Bisphosphonates reduce osteoclastic activities, and osteoprotegryn interferes with the rank ligand system to inhibit osteoclasts. Before we wrap up this video, a quick look at metal debris. The size of metal wear particles is much less than the polyethylene. Note that polyethylene wear particles are 0.5 microns in size, whereas metal debris are in nanometers. The main immune cell that deals with metal debris are lymphocytes, unlike in polyethylene where macrophages are more predominant. The local soft tissue effects, also called adverse reaction to metal debris, can be appreciated on an MRI as pseudotumors and histologically in the form of metallosis, tissue necrosis, and alveolar reaction. Some of the systemic effects of metal wear particles are autoimmunity, usually to nickel, DNA damage due to chromium, cardiomyopathy, and oncogenesis due to cobalt. We have now come to the end of this video. Thank you for watching.